Hello, this is single gene genetic disorder presented by the SchrDbb. We will reference ABC Clinical Genetics by Helen Kingston. So, in this single gene disorder, mostly we are going to speak about Mendelian inheritance method. So, Mendelian inheritance method. So now, what are some examples of autosomal dominant adult onset disease that are affecting the central nervous system. So the disorders that we're going to see in single gene disorders are mostly going to be based on the different systems. Is it clear? So we are going to start with the central nervous system, and we have different single gene disorders, mostly transmitted by Mendelian pattern. Is it clear? So affecting the central nervous system, the first one, we have familial Alzheimer's disease, which is going to be divided from 1 to 4, and it has different genes associated with it. We have familial amyotrophic lateral sclerosis, which has the different genes associated with it, the different genes associated with it. We have familial Parkinson's disease, has the gene associated with it. We have frontotemporal dementia with Parkinsonism, the gene associated with it. Creutzfeldt-Jakob syndrome has a gene associated with it, and mostly that Creutzfeldt-Jakob syndrome is due to a prion or a viral particle, and it is initiated by so this is a demyelinating Creutzfeldt-Jakob syndrome. I'm going to speak specifically because it's one of the side effects of blood transfusion, and that's why we say blood transfusion, you have to do it in extreme cases. Is it clear? It's only when the patient is decompensating and having a hemoglobin level, it's decompensating because of low hemoglobin level, that you give blood transfusion. Don't give in every cases. So certain people can develop the Creutzfeldt-Jakob syndrome, meaning that you have a demyelinating disease of the brain, which is because of prion or viral particles inside the blood. Is it clear? So this prion cannot be detected by certain screening methods, by all the screening methods. So it is only present there and can result to Creutzfeldt-Jakob syndrome. Now, the next one is cerebral autosomal dominant arteriopathy. So, in fact, and leukoencephalopathy. So, these are the gene associated, and we have familial British dementia, the gene associated. Now, in central nervous system, we are going to mostly speak about Huntington's disease. And Huntington's disease, we say it's an autosomal dominant disease which is characterized by progressive choreiform movement. When I say choreiform movement, it's just repetitive involuntary movement. That's choreiform movement. There is rigidity, there is dementia from selective localized neuronal cell. We also have the localized neuronal cell that associated with atrophy, and the coded nucleus is demonstrated by CNS imaging like MRI. Now we need to know that what Huntington's disease, the gene of Huntington's disease was mapped to the short arm of chromosome 4. Is it clear? The gene of Huntington's disease, short arm of chromosome 4, but not cloned. Is it clear? Till 1993. Those are the things that you have to know. Now, the mutation that is underlying Huntington's disease is because of the expansion of the CAG trinucleotide repeat sequence. So, when you have an expansion of cytosine, adenine, and guanine trinucleotide, which is greater than 37 to 86 repeat copies, that is when you are going to have the Huntington protein, and that Huntington protein is going to give you Huntington disease. So now we say that usually Huntington's disease is going to be present in adult age. So when you have a patient in low age, they are not going to develop Huntington's disease, only as from adult age that they are going to develop it. Is it clear? Now, these are certain common disorders here. There are common disorders with their inheritance pattern, with the gene product. So if you have tried certain central nervous system disorders or neurologic disorders, you have child onset spinal muscular atrophy, it's also autosomal recessive. We have the gene which is affected, Kennedy syndrome. These are all the diseases which are in central nervous system and their inheritance pattern. X-linked recessive, autosomal dominant, autosomal recessive. These are all their autosomal pattern, their inheritance pattern, and these are the gene product that are in cause of those diseases. After speaking about the Huntington disease, we go now to the Fragile X syndrome. So Fragile X syndrome, it is just it's a common single cause of inherited mental retardation. So if they ask you the question, what is the most common single gene disorder which is due to resulting to mental retardation, the answer is Fragile X syndrome, and the transmission is 1 in 4,000 males. Is it clear? So it's an X-linked disorder. That's why it's called Fragile X from the name. You can see it's an X-linked disorder, mostly affecting males. Is it clear? So the clinical phenotype comprises of mental retardation is the first thing. You can have also macro-orchidism. Macro-orchidism, why? Because the X chromosome is affected, so the Y chromosome is going to be in excess. So we have macro-orchidism, we have prominent head, large jaw. All these are characteristic of excess testosterone, which is because of excess of the Y chromosome over the X chromosome. Is it clear? So you can do now chromosomal in order to see the Fragile X syndrome. As you can see here, you can do karyotyping with the Guillermo-Sazinian electron microscopy to visualize the disorder with Fragile X syndrome. So you can see the ends of the X chromosome can be deleted. Is it clear? So they say that this observation, you can observe that you have an expansion in the Fragile X syndrome. You can have an expansion of the CGG trinucleotide repeat gene of the FMR1 gene. Is it clear? So those are the molecular analysis. So you can do molecular analysis now, confirm the diagnosis of the Fragile X syndrome. But the first way to see it is by karyotyping, and you can do the fluorescence to hybridization. But molecular analysis method is going to confirm your Fragile X syndrome. So we are going to visualize different molecular and all that. So now this is Fragile X syndrome pedigree. Is it quite clear? When males are affected, they are coming from the mother carrier. Males affected coming from mother carrier. The males affected here are coming from one mother carrier. Is it clear? And when a father is going to be a carrier, the mother must be a carrier. So that is just telling you that it's an X-linked disorder. Now, what are the examples of neuromuscular diseases? Example of neuromuscular diseases, Duchenne muscular dystrophy and Becker muscular dystrophy. All of them have the same clinical pattern, and all of them have the same genetic pattern, because it's because of the dystrophin gene. Is it clear? But the difference is that Duchenne muscular dystrophy usually occur in early ages, while Becker muscular dystrophy occur in later ages. That's the main difference between both of them. Is it clear? So Duchenne muscular dystrophy is an X-linked, and Becker, they are X-linked dystrophin genes. So they are X-linked recessive genes. Is it clear? So in Duchenne muscular dystrophy, the incidence is 1. So the incidence is around 1 in 3,500 male death births in Duchenne, while and it has reduced to around 1 in 5,000. So all those are the clinical pattern. Now, what is the clinical features? So the clinical features you can see from this patient here, you have scapular ringing of the scapula, you have lordosis, you have enlarged calves. So those are certain characteristics that the patient are going to have. And now on the clinical examination, you can do the Gower maneuver. On the Gower maneuver, the patient is going to try to stand with the 2 hands. So the 2 hands is going to press on the floor, and since the legs are very weak and the knees are very weak, so since the legs are very weak, in Gower maneuver is that when the patient wants to stand up, he's going to press the 2 hands on the floor in order to stand up. And when he stand up, so that is when he's going to, you see, he's pushing the floor with his 2 hands in order to wake up. And in order to stand up straight, you see that he's going to place now his hands at the level of the knee in order to push the knee, so for him to stand up straight. That is a child demonstrating a Gower maneuver. Is it clear? So this is the Gower test, and it's with WER test. So that is how it's demonstrating. So this is because the lower limb is very weak, so they try use to the hand to compensate for that weakness. Now the next one is we also have this difference. So you have marked wasting of the thigh. So you have marked wasting of the thigh, and you have calf hypertrophy. Is it clear? So the quadricep muscles here are not functioning well, but the calf at least they are functioning. So calf hypertrophy. We have also scapular winging. And so in cases of a patient now with Becker muscular, so we see that in Becker muscular dystrophy occurring later in ages, while Duchenne muscular dystrophy is occurring early ages. Is it clear? Early ages, and usually they are going to die because of acute kidney injury from what is going to kill them is an acute kidney injury from what? From a rhabdomyolysis, because of excessive degeneration of their muscular tissues. Now the next one is myotonic dystrophy. So for myotonic dystrophy, so it's another disease here. So myotonic dystrophy is an autosomal dominant disease, and 1 in 3,000 people are going to have that disease. And this order is due to an expansion in the trinucleotide repeat sequence of the dystrophia myotonica protein kinase gene. That's the gene affected. Now, the classical myotonic dystrophy is a multi-system disorder that presents with myotonia, that slow relaxation of muscle tissue of voluntary after contraction. That is myotonic. So you have relaxation is slow, so there is tonia. Relaxation is slow after contraction. That's myotonic dystrophy. Is it clear? So you have molecular. So those are the different things. So you have different clinical patterns that you have, but you need to know that molecular analysis identify the extended CTG gene on that myotonia dystrophy gene. Is it clear? So this is a patient with myotonia dystrophy with ptosis and facial muscle weakness. So because of excesses of the contraction of the muscle. Now these are the muscular dystrophy with genetic defects. So you need to know that there are many muscular dystrophies, muscular diseases based on genetic single gene genetic inheritance. You can have a congenital Duchenne muscular dystrophy with your protein deficiency. Protein deficiency can be assessed with biochemical analysis, and you have the gene deficiency assessed with molecular genetics, and you have the inheritance method. Now you have Emery-Dreyfus syndrome is another one with muscular dystrophy, their protein deficiency, their gene disorder, their protein deficiency, and their clinical inheritance method and all that. So now neurocutaneous disorder. So example of neurocutaneous disorder, you have neurofibromatosis. Is it clear? So neurofibromatosis actually it was initially described by von Recklinghausen. That is why neurofibromatosis type 1 is also called von Recklinghausen syndrome. Is it clear? And now that neurofibromatosis type 1 usually occur in 1 in 3,000 people. Now, what are the diagnostic criteria of neurofibromatosis type 1, which is also called von Recklinghausen syndrome? So we have 6 or more cafe-au-lait spots. So when you have cafe-au-lait macules that just resemble like cafe-au-lait, those are, and they are going to be greater than 5 millimeters in diameter before puberty, or greater than 15 millimeters in diameter after puberty. You can diagnose it. The second is that you can have 2 or more neurofibroma. Neurofibromas are going to be raised lesions, raised nodules on the skin. You have 2 or more neurofibromas of any type, or one plexiform neuroma. So a plexiform neuroma is just going to be multiple neurofibromas which is going to follow a particular nerve root. That's a plexiform neuroma. Is it clear? You can have also flecklings in the axillary, freckling in the axillary or inguinal region. You can have 2 or more Lesch nodules. Lesch nodules are going to be located at the level of the eye. You can have optic glioma. You have bony lesions of pseudoarthrosis. You can have pseudoarthrosis, you can have thinning of the long bones and first degree ischia and all that. So what are the complications of neurofibromatosis? One, you have plexiform neuromas, you have congenital bowing of the tibia and the fibula due to the pseudoarthrosis, you have optic glioma, scoliosis, epilepsy, hypertension and all that. So these are multiple neurofibromas. You can see rashes here on the skin, and you can also see scoliosis at the level of neurofibromatosis 1. Now the diagnostic criteria. Now in case of neurofibromatosis 2, is it clear? Neurofibromatosis 1 and 2 are associated with different chromosomes, is it clear? Neurofibromatosis 1 is localized on chromosome 17, is it clear? And neurofibromatosis 2 is going to be localized on chromosome 22. Those are the differences, is it clear? And the diagnostic criteria of neurofibromatosis 2 is that what? You have bilateral vestibular schwannoma, is usually affecting the ears. With bilateral vestibular schwannomas that you can diagnose. You have first degree relative with neurofibromatosis 2 and either unilateral. So if you have a first degree relative of neurofibromatosis 2 and you have either a unilateral vestibular schwannoma, that is schwannoma on one vestibule, or you have any of the two listed below. If you have a unilateral vestibular schwannoma and two or more other features listed below, like multiple meningiomas with one other feature listed below. So these are the different features which are listed. So either you have a unilateral schwannoma, or you can have a bilateral schwannoma, or you can have family history of neurofibromatosis 2 with unilateral vestibular schwannoma, or you have two of these features. Either you have a meningioma, you have a glioma, you have a schwannoma, posterior subscapular lenticular spasticity, and all that so are located in this case. So you can just look the table and to get more terms. Now tuberous sclerosis complex. So you need to know that tuberous sclerosis usually occur as a pleiotropy. It means that it's associating many signs and symptoms which have different, which have completely different relationship. Is it clear? Tuberous sclerosis occur in 1 in 6,000 people, and it's an autosomal dominant disorder. Is it clear? So these are the different manifestations of tuberous sclerosis. Sometimes it manifests with hypomelanotic macules. You have facial angiofibroma. You have chagrin patch. So these are example of facial angiofibroma here. This is an example of periungual fibroma. So you can also have an ungual fibroma. You can have dental enamel bits. And this third one here is an example of depigmentation, leaf depigmentation of toxic, and this is an example of retina of hematoma in tuberous sclerosis. Is it clear? Hematoma in tuberous sclerosis, as you can see here, like that. These are the different retinal astrocyte hematomas, as you can see, in tuberous sclerosis. So all these are the clinical features, and each of the clinical features have different frequency of occurrence, because tuberous sclerosis is one of the autosomal dominant diseases that does a high level of variation. Some people may have all of them in severe form. Some people may have only one of them, that is the chagrin patch. Some people may have extreme and other, that is variation, and some people may not even have any of them, like in case with a very high penetrance. Is it clear? So when the disease has a very high penetrance ability for it not to be expressed in certain population. Now the next ones are connective tissue disease. Connective tissue disease example is Marfan syndrome. Marfan syndrome is an autosomal dominant disorder of connective tissue. We actually with the fibrillin 1 gene. Is it clear? Now the clinical features of Marfan syndrome, we have major features, we have minor features. Minor feature, we have the thumb sign, and the thumb sign is what? The thumbnail protrude beyond the ulnar border of the hand when adducted. So the simple way of explaining is that you try to close your fist. Is it clear? With the thumb sign is that when you close your fist and then your thumb is going to cross. You know that when you close the fist, your thumb cannot cross the fifth finger. If you close the feet and the thumb crosses your fifth digit, crosses over the fifth digit to the palmar aspect. If crosses over the fifth digit to the palmar aspect, it means that that's the thumb sign positive. Now the next one is the wrist sign. The wrist sign is the thumb and the fifth digit overlap together encyclically. Now that's the wrist sign. What I was saying was just the wrist sign. But now the thumb sign, the thumb is going to protrude. The thumb is going to protrude beyond the ulnar border of both hands when adducted across the arm. So when you try to bring your thumb closer, the thumb can protrude into the ulnar aspect. The next one, you have reduced upper and lower segment ratio. It means that you calculate the upper segment ratio actually is from year to year. Is it clear? Or you calculate from the upper segment ratio of the body is from the pubic symphysis upward. Is it clear? Or you can just take from anterior superior iliac spine upward. Is it clear? That's the upper segment of the body. So if you want to calculate the upper segment and the lower segment, in order to calculate the upper segment of the body, the simple thing to do is ask the patient to sit down. Is it clear? When you ask the patient to sit down, to calculate upper segment is just you take the height from head to the place where the patient is sitting. That's the upper segment of the body. And now the lower segment of the body is going to be the total height minus the upper segment. You're going to have the lower segment of the body. Is it clear? So you have now a reduced upper lower segment. Is it clear? Normally the upper segment is going to, the lower segment is going to be greater than the upper segment. Normally the lower segment is slightly greater than the upper segment, and when you calculate, they are going to be, it's going to be approximately 0.85. Is it clear? But now if the lower segment is extremely greater than the upper segment, you are going to have a very low value, less than 0.85. That's the reduced form. So now you have increased span and height ratio. You can have increased span and height ratio. You have pectus carinatum, that is pigeon chest, pectum excavatum requiring surgery. You have scoliosis, 20-degree difference with or a spondylolisthesis. You have reduced elbow extension. You have pes planus or flat foot. So those are the different. Now the minor features, you have pectus ecmogen, pectus excavatum. You can have joint hypermobility. You have high arc palate and all that. So those are the characteristics. So this is an example of pectus excavatum. Excavatum is going inside, while carinatum is going protruding outside. That is, these are multiple striae in case of Marfan syndrome. Now these are dislocated lenses in case of Marfan syndrome, which can be seen with a fundoscope or an ophthalmoscope. So those are the different diseases in Marfan syndrome. And now you need to know that what Marfan syndrome is mapped to chromosome 15 cure. Is it clear? That is where the fibrillin gene is going to be located on. And this syndrome can be seen now in cases of if you have now the mutation that is for fibrillin 1 gene, you're going to have Marfan syndrome. But if you have mutation in fibrillin 2 gene, you are going to, the cause is going to the fibrillin 2 gene cause a phenotypically related disorder to Marfan syndrome, which is called Bill syndrome. So if you have a fibrillin 2 gene disorder, is it clear? You are going to have instead Bill syndrome, which is contractural arachnodactyly. Is it clear? Characterized by doli costenomelia. Actually, it's long, slim limbs. So it's similar parts in the Bill syndrome. Is the same as, is quite the same as Marfan syndrome. Now the next one is cardiac and respiratory disorder. So cardiac and respiratory disorder, the first one, you have cystic fibrosis. Cystic fibrosis is the most common lethal autosomal recessive disorder of childhood. in Northern European country, the most common. And then the probability for it to occur is that the incidence of cystic fibrosis is approximately 1 in 2,000 people, with 1 in 22 people of the population to be a carrier. Incidence for it to occur is 1 in 2,000, but for you to be a carrier is 1 in 22 people. Is it clear? Now, we have certain characteristics of cystic fibrosis. What are clinical manifestations? We have pancreatic malfunctioning, because here there is an abnormality of the chloride ion channels. Is it clear? And then chloride ion channels are also important in the pancreatic function. We have pancreatic malfunctioning like malabsorption. We have intestinal gland malfunctioning like meconius ileus. We have bile duct malfunctioning like biliary cirrhosis. We have bronchial glands malfunctioning like the chronic bronchopulmonary infection with emphysema. We have sweat gland malfunction. We have abnormal sweat electrolyte. We have gonadal malfunctioning like infertility. So those are the different clinical presentations. But now you need to know that what cystic fibrosis is due to mutation of cystic fibrosis conduction regulator gene. So the CFTRG gene, the cystic fibrosis conductance regulator gene, which is a chloride ion channel disease affecting the conductance pathway of salt and water. Is it clear? And in order for you to diagnose the sickle cell disease, you can use the sweat test. Which contains, so you see that there is abnormal chloride. You're going to have abnormal chloride and sodium ion inside the sweat. So is it clear? Now we have chromosome. This gene, which is CFTR gene, is going to be located on chromosome 17q31. That is the location there. Is it clear? Okay, those are the points. And now in order for you to diagnose the cystic fibrosis disease, you can use the sweat test as an initial diagnosis. I can support that cystic fibrosis. Now to confirm completely cystic fibrosis, you must do molecular genetic analysis. Now these are the different genes which are involved in causing cystic fibrosis. Cystic fibrosis, in that CFTR gene, multiple genes are found inside it. You can have the C85E gene, you can have the R1117 gene, but among all of them, the most cases of cystic fibrosis is due to the delta F508 gene. Is it clear? So these are this mutation, this particular mutation can easily affect this gene. So these are the different mutations that can occur based on the biogenetics. That is not the tutorial, the chapter of today, but this particular mutation in biogenetics is going to be affecting that CFTR gene to cause mutation, because we have a frequency of 88%. Now the next one, we have single gene disorder associated with congenital heart disease. Some people have congenital, some children have congenital heart disease, and the congenital heart disease exists in syndromes. Is it clear? So the example of this syndrome, we have Holt-Oram syndrome. Holt-Oram syndrome, we have upper limb defect, atrial septal defect, we have cardiac conduction defect. We can have also Nano syndrome. Nano syndrome is a Turner-like phenotypic disorder with cardiomyopathy, pulmonary stenosis, and deafness. Leopard syndrome, we have multiple lentigens. So leopard syndrome, we just have striae like leopards. Is it clear? So that's multiple lentigens. You have pulmonary stenosis, you have cardiac conduction defect. You have Ellis Van Creveld syndrome with this, and you have also tuberous sclerosis, which exists as a pleiotropy. Is it clear? So you can have also patient with cardiomyopathy. Mostly the cardiomyopathy which is going to be affected in an autosomal dominant pattern is a hypertrophic cardiomyopathy, and it is inherited. And in cases where you can have cardiomyopathy in a syndrome, you have in this case here in Nano syndrome, where you can have cardiomyopathy in a syndrome. Is it clear? Now gene, so that is for cardiomyopathy. Is it clear? So dilated cardiomyopathy actually is not much of dilated cardiomyopathy can be of inherited pattern or may not. What is mostly of of inherited pattern is hypertrophic cardiomyopathy. And hypertrophic cardiomyopathy, 1 in 1,000 people are going to have the disease of hypertrophic cardiomyopathy. Is it clear? You have hypertrophy without dilation. Is it clear? So hypertrophic cardiomyopathy, we have now the gene involved here in encoding myosin and troponin with alpha topomyosin is having the disorder. So you have mutation analysis routine, but the mutation detect is pre-symptomatic. So actually this is the gene affected. Now in dilated cardiomyopathy, actually what they are saying that what it has a considerable heterogeneity. Most of the time dilated cardiomyopathy is not inherited. It may be due to the environmental factors. Is it clear? So when you have a mutation in the alpha actin gene that you can have, that is located at the level of the X-linked disease. So X-linked, so that is X-linked, the alpha gene which is X-linked, you may have a Barth syndrome. Is it clear? Which is associated also with skeletal myopathy and neutropenia. So dilated cardiomyopathy can exist also with Barth syndrome. In inherited form, it can exist with Barth syndrome, with skeletal myopathy, neutropenia. Is it clear? It can also exist with Duchenne and Becker muscular dystrophy. They have the same clinical pattern. Now, restrictive cardiomyopathy is due to autosomal recessive inborn error of metabolism. Is it clear? So those are the different cases you have to know. Now, these are the gene causing autosomal dominant hypertrophic obstructive cardiomyopathy. So for hypertrophic cardiomyopathy, these are the different genes involved. So you can have and then they have heterogeneity, means that what they have located on different locus, the gene that causes hypertrophic cardiomyopathy. You can have a cardiac myosin heavy alpha and beta gene which is located on the FHC1 location, with this is the chromosome on which they are located. They have different gene location. It is just like the sensorineural deafness gene. Cardiomyopathy gene is located on different chromosomes, different locus. That is called locus heterogeneity. These are the different genes involved, and these are the different locus, and these are the different gene location on chromosomes. So the genetic disorder with associated cardiomyopathy. So we had the first one, which was Duchenne and Becker muscular dystrophy. Is a genetic disorder. At first, here we speak about syndromes which were associated with congenital heart disease. But now these are not with only with congenital heart disease, but cardiomyopathy. These are kinetic disorders which are associated with cardiomyopathy. We have Duchenne and Becker muscular dystrophy. We have Emery-Jeffel muscular dystrophy, mitochondrial myopathy, myotonic dystrophy, Friedreich ataxia, and Noonan syndrome. And these are their inheritance pattern. Now, familial cardiac conduction defect. So usually the familial cardiac conduction defect is divided into two. So certain children may be affected, may be born with conduction defect, with heart blocks, with arrhythmias. So all that, so heart block, is it clear? So most of these children, you can have a long QT syndrome. So both of them have long QT syndrome. So now you can have a Romano-Ward syndrome, which is an autosomal dominant. You have this episodic dysrhythmia in quarter of patients. You have a risk of sudden death. So when certain children die suddenly, the answer is not usually that it is witchcraft like in our context. No. So the answer may be that they have this syndrome, a cardiac conduction defect. Is it clear? They have a cardiac conduction defect, and that cardiac conduction defect is one of the causes of sudden child death in a normal child. So usually the cause of sudden child death, it can be due to a cardiomyopathy. A sudden death may be due to a cardiomyopathy, or sudden death may be due to also a conduction defect like Romano-Ward syndrome. Is it clear? So it has also several loci, just like hypertrophic cardiomyopathy, and there are mutations. The mutations actually due to sodium and potassium channel genes. Also, we have the Jervell and the Lange-Nielsen syndrome. Here, in this case, autosomal recessive and it's associated with congenital sensorineural deafness. Is it clear? You have a considerable risk of sudden death. You also have here a risk of sudden death, and then the mutation is the potassium channel. Is it clear? So those are the different things that you should note, that certain children die because of sudden death because of these syndromes. Now, hematology disorders. For hematology disorders, you have things like hemophilia and hemophilia A and B. In hemophilia A, B with von Willebrand disease, hemophilia A is a bleeding disorder which is affecting 1 in 5,000 people, so 1 in 10,000 males. It's an X-linked recessive disorder which is affecting the factor 8. Is it clear? That is hemophilia A. While hemophilia B is affecting factor 9. Is it clear? So those are the different cases of hemophilia. Here you have a stage, or in hemophilia you actually don't have a problem with primary hemostasis, but you have a problem with secondary hemostasis. In primary hemostasis, when you have things like thrombopenia, so when you have low level of platelet cells, usually it presents with bleeding underneath the skin, like PTK all around, or you have bleeding gums. Is it clear? So when you have superficial bleeding, it's because of low level of platelets. But now low level of secondary hemostasis is going to cause you a deep bleeding, like intra or even an occult bleeding. It can cause you hematrosis. Is it clear? It can cause this hematrosis, like hemophilic arthropathy. It means that what you can bleed in your joint. Usually these people are going to bleed in their joint. Is it clear? And they have also a long bleeding time. So you have hematosis is one of the major presentation of these patients with hemophilias. Now, hemochromatosis. So hemochromatosis is a common autosomal recessive disorder. So 1 in 10 people are going to be heterozygous. Is it clear? It means that 1 in 10 people are heterozygous with hemochromatosis. Not all homozygous are clinically affected. Why? Because of what I just said was variation and penetrance. So clinical features is that you have iron deposition, can cause liver cirrhosis, can cause diabetes. You can have iron deposition at the level of the pancreas, at the level of the liver. So at the pancreas, it's going to cause diabetes. At the level of the skin, cause skin pigmentation. At the level of the heart, that is bronze skin in hemochromatosis. You can have bronze skin, and at the level of the heart, you can have heart failure. So primary hepatocellular carcinoma can occur after a long deposition to the liver. So what is the management? The management is is phlebotomy. You always, in this patient are centers for removal of blood. Actually, they have to donate blood after every 3 months. Is it clear? Even 2 packs of blood, because they have enough iron in their body. Is it clear? So you have early diagnosis of decision organ. So is it clear? Normal life expectancy. So what is the diagnosis? So the diagnosis, to make a diagnosis now of hemochromatosis, you look for the ferritin level. The ferritin level is going to be extremely high, and the transferrin level, like the transferrin level is going to be extremely low. Is it clear? So and then the liver biopsy is going to give you a conclusion. Now, genetics. How do you know now the genetic analysis now of hemochromatosis? So the genetic analysis that you have mutation on the hemochromatosis HFE gene. Is it clear? And these are the 2 mutations that you can have. You can have this mutation and this mutation based on the biogenetics. And greater than 80 people are going to be affected in Northern Europe. It is not usually found in our context. So these are the genes that are going to be affected. Now in hemophilia, the gene is going to be hemophilia A. The gene affected is going to be factor 8 gene. Is it clear? And in hemophilia B, is still a like X-linked recessive disorder, but less frequent, affecting the factor 9 gene. Is it clear? And that factor 9 gene is also X on cure 27. Now, what is example of of single gene disorder which affect the renal system. We have tuberous sclerosis. You see, tuberous sclerosis has excessive of pleiotropism. It is everywhere. Everywhere you just hear tuberous sclerosis, it is affecting all the systems. Is it clear? Tuberous sclerosis. We have von Hippel-Lindau syndrome disease is very common, and these are the features of von Hippel-Lindau disease with renal cell carcinoma in the kidney, retinal angioma, and renal and cerebral hemangioma. You have infantile polycystic kidney disease, cystinuria, cystinosis, Jeune syndrome, Merkel syndrome, Alport syndrome, Fabry's disease, Lesch-Nyhan, and Lewis syndrome. All these are the inheritance pattern. Here we are going to speak about the next one, which is we're going to speak here about the adult polycystic kidney disease. Okay, so adult polycystic kidney disease is a late onset autosomal dominant disorder characterized by multiple renal cysts. Usually it is occurring late onset, characterized by multiple renal cysts, common in human, and the incidence is 1 in 10,000 for adult polycystic kidney disease. Now, all affected individuals have renal cysts detectable on ultrasound by the age of 30 years. So, to diagnose adult polycystic kidney disease, you must have bilateral multiple cysts on your renal ultrasound to make your diagnosis. And now lastly, we have also genetic diagnosis. Like there is a locus heterogeneity. We have to know that there is a locus heterogeneity with adult polycystic kidney disease with at least 3 loci which has been identified. Is it clear? So the gene, we can have adult polycystic kidney disease, one locus located on chromosome 16p and encode for polycystin 1 protein. Is it clear? We have also adult polycystic kidney disease gene 2 located on chromosome 4 and is used for polycystin 2 gene. And the last one, which is adult polycystic kidney disease 3 loci, has not yet been well studied. Now the next one are the example of syndrome associated with deafness. These are examples of syndrome associated with deafness. The first one is Pendred syndrome, Usher syndrome, Jever-Lange syndrome with cardiac conduction defect, which has a risk of sudden death. You have Treacher-Collins syndrome. You have Waardenburg syndrome. Is very common with deafness, with nerve deafness, pigmentary abnormality too. You have bronchio-otorhinal syndrome. You have Stickler syndrome, and you have Alport syndrome. Alport syndrome is also associated with renal failure. So you have nerve deafness and you have renal failure. Is it clear? So these are the different inheritance patterns. So for the deafness, so you can have severe congenital deafness. So severe congenital deafness affect 1 in 1,000 infants. They may be isolated deafness or part in syndromes like where we have seen here. So you can have different cases. It can be 66% of the severe congenital deafness is autosomal recessive, 31% is autosomal dominant, and 3% are X-linked. Is it clear? Over 30 autosomal recessive loci have been identified. So you see that this severe congenital deafness for autosomal recessive condition, there are 30 loci that has been identified. As I've told you, it also exhibits locus heterogeneity. Now the next one is connexin 26 mutation, still causing deafness. So this is a mutation of the connexin 26 gene on chromosome 13 and have been found to be autosomal recessive congenital deafness. Is it clear? It's another form. So this is one of the autosomal recessive congenital deafness on chromosome 13 with the connexin gene. So the connexin 26 gene encode a gap junction protein that form a plasma membrane channel that allows small molecule and ion to form at the cell border. So this is an example of a diagnostic representation of the pendrin protein, which is found in Pendred syndrome. We have to speak about that now. So Pendred syndrome is an autosomal recessive form of deafness that is due to cochlear abnormality associated with thyroid goiter. Is it clear? The gene for Paget syndrome is the PDS gene, and was isolated in 1997 on chromosome 7. Is it clear? So that is the Paget syndrome with the Paget protein, which is located here. Now for the eye disorders, so these are examples of autosomal eye disorders, and these are examples of autosomal recessive disorders, and there are also examples of autosomal X-linked recessive eye disorders. So for autosomal dominant eye disorders, you have late onset macular dystrophy, best macular degeneration, retinitis pigmentosa, and all these disorders here with sickle syndrome. With autosomal recessive disorder, we have the juvenile Sjogren macular dystrophy, retinitis pigmentosa. You see, retinitis pigmentosa is in two forms because of variation. You have Leber congenital amaurosis, you have hereditary optic atrophy, so we have congenital cataract. Now for X-linked recessive disease, you have color blindness, ocular albinism, and all these are also located here. So now we start with retinitis pigmentosa. So retinitis pigmentosa. Retinitis pigmentosa is the most common type of inherited retinal degenerative disorder. So the most common type of inherited, not eye disorder. It's not the most common type of inherited eye disorder, but the most common type of inherited retinal degenerative disorder. Like other eye condition, it is genetically heterogeneous. So there is heterogeneity like other eye condition with different locus and different genetic heterogeneity. So it is autosomal dominant in different cases. So it is so autosomal dominant. So in 25% of cases, it is autosomal recessive in 50% of cases, and X-linked in 25% of cases. That is the heterogeneous pattern. So is it clear? So when they say that when you have always spoken about locus heterogeneity, and in case of the genetic heterogeneity, like in this case, you have different forms of presentation. Is it clear? It can be autosomal dominant in genetic heterogeneity, it can be autosomal recessive, and it can be X-linked. Autosomal dominant in 25% of cases, autosomal recessive in 50% of cases, X-linked in 25% of cases. So, and here the retinitis pigmentosa is associated with mutation on rhodopsin and the peripherin genes. So those are the two main genes affected. Now the skin and diseases. So skin diseases here, these are examples of Mendelian affecting the skin. So you have ectodermal dysplasia with all this, you have ichthyosis with all this, and we have also keratoderma with all this, with follicular hyperkeratosis. Now epidermolysis bullosa. Epidermolysis bullosa is a clinically and genetically heterogeneous group of blistering skin disease. The main type is designated simplex junctional and dystrophic. So those are the three main types: epidermolysis bullosa. And epidermolysis bullosa, generally the clinical presentation is that what you have when you scratch your skin yourself, you have bullet that are going to be formed. The majority of cases are autosomal dominant mutation of the keratin 5 and the keratin 14 gene. Is it clear? So it is usually going to be affecting the integrin and the type 17 collagen. So those are the different cases. And then mutation associated with specialists and all that can be, you can do gene therapy in order to stop the epidermolysis bullosa. So from here we can say thanks to that you are finished with all the single gene disorders with Mendelian inheritance. Say thanks for your kind attention. Don't forget to like and subscribe for our channel. Thanks very much.